Hello, I'm Dr. Reha Rakhulia. Today's topic is Aphrodite Criteria. Hi, today we'll talk about Aphrodite Criteria. Actually, it is similar to the Poseidon criteria. In poor responder, we read Poseidon criteria in females. Similar to that, it's in male Aphrodite criteria. Now, it is addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. Okay, what does that mean? Hypogonadism. Hypogonadism means body produces little or no hormones, no sex hormones. Like here we are talking about testosterone. Okay, it can be either, we are talking here, hypogonadism word is there, so it can be either primary or secondary hypogonadism. What is the cause of primary hypogonadism? It can be primary hypogonadism means primary testicular failure. Testicular failure, okay? And secondary hypogonadism means testis is normal. Testis normal, but hypothalamo pituitary fails to signal testis to produce testosterone. This now, what is the cause of primary testicular failure? It can be due to trauma, infection, chemotherapy, or radiation. Okay. Now, second term we are hearing here is altered idiopathic testicular function. Altered idiopathic testicular function. What does that mean? Idiopathic. Idiopathic means cause is unknown. Cause is unknown. Means changes or abnormalities in testicular function. Testicular function where there is no identifiable cause. Okay, that is idiopathic. Pathic testicular function. So Aphrodite is clear here. Aphrodite is addressing male patient with hypogonadism and or infertility owing to altered idiopathic testicular function. Okay. This is the article we are discussing here. This was by Sandro Esteves. Okay, it's in 2024. It was published in RBMO. So purpose of Aphrodite criteria. What is the purpose of Aphrodite criteria is it classify male infertility. It classify male infertility and it discovers new treatment, new pharmacological treatment. Third, like right now for male infertility, there is no standardized approach. Standardized approach is not there. So like andrologist is treating differently, reproductive medicine and surgery is treating differently, urologist is treating differently. So to make the standard approach standardized, this criteria was purpose of this criteria is to make the this standardized treatment standardized. Now we have already discussed about the what it stands for is addressing male patients with hypogonadism and or infertile owing to altered idiopathic testicular function. This we have already discussed. Now, endocrine balance. What we have to do in endocrine imbalance? We'll have to counsel and treat the patient. Okay, we'll have to counsel an endocrine imbalance. We'll have to counsel and treat the patient. It can if we will treat the patient, it can increase natural and assisted conception, both natural and assisted conception. How natural conception? It can increase the, if we treat the endocrine imbalance, it can increase natural and assisted conception. How? In natural conception, it is it can increase sperm concentration in ejaculate. How assisted conception? It can improve sperm retrieval rate. It can improve sperm retrieval rate. Like more sperm will get, improved quality sperm will get, quality and quantity, both. We can get good quality and good quantity of sperms. Okay. What this Aphrodite criteria is based on? It is based on clinical patient description. Clinical patient description. Second is semen analysis. Third is hormonal test. Basically, two hormonal tests they have done. One is FSH and another is testosterone, total testosterone. Okay. Now, there are 5 distinct groups. They have made 5 distinct groups of this Aphrodite criteria. First is hypogonadotropic hypogonadism. Okay. It can be acquired or congenital. Second is idiopathic male infertility. Idiopathic male infertility. What will happen in this? There will be decreased semen analysis, but normal FSH and total serum testosterone is normal. Only in the second criteria, only semen analysis will be there will be lowered semen analysis. Okay. No, there will be normal FSH and testosterone, total testosterone. Then third is hypogonadal state with lowered semen analysis parameter and normal FSH, reduced total testosterone concentration. Means there will be decreased semen analysis. Third group has decreased semen analysis, semen parameter and decreased serum testosterone, total testosterone, but FSH is normal. In third, total testosterone and semen analysis is decreased. Fourth is decrease semen analysis, increase FSH, means hypergonadotropic, increase FSH, decrease semen analysis, decrease or normal testosterone, total testosterone level. This one is fourth. This one is hypergonadotropic. Fifth is unexplained. Then global impact of infertility. Okay. Infertility in 1 in 6 couple globally, 1 in 6 couple is affected with infertility. Around 1 in 6 couple of reproductive age worldwide. Okay. Now, what is the male contribution? Male factor contributes 50%. 50% contribution, and significant contribution means they are the cause. In significant contribution means they are the cause. Significant contribution in 20%. Contributors are male factor contribute to about 50% of infertility and significant contributory factors in approximately 20%. Okay. Now, challenges. What are the challenges? First of all, male infertility has, first challenges, male infertility has diverse causes, many causes, diverse causes and contributory factor. Okay. Male infertility is having diverse causes and contributory factor. Many causes are there. What are these? They can be congenital, genetic, anatomical, hormonal disturbances can be there, hormonal disturbances. Ejaculatory dysfunction can be there. And lifestyle habits, wrong lifestyle factor can be there. First challenge is this, okay, diverse causes and contributory factors. Second challenge is heterogeneity in specialist. There may be heterogeneity in specialists, like I already told, andrologist, urologist, reproductive medicine and surgery. These all may have different treatment. Lack of cohesive treatment. Lack of cohesive treatment can be there. So there may be high proportion of men who are untreated or receive empirical treatment. Okay. Now, clinical assessment, semen quality and quantity typically used as a measure of male fecundity. Quality and quantity, male fecundity, it can be used for. What is fecundity? Fecundity is conceive and produce a viable offspring, viable, live offspring. Spring. Okay. How will we remember it? Fecundity. Mnemonic is DT. DT means duty. Duty is to bring some live birth. Duty is to bring some live birth. This is mnemonic to learn what is fecundity. And then diagnostic treatment planning require cohesive evaluation beyond basic semen analysis. What we have to we'll have to like think beyond semen analysis. We'll have to think beyond semen analysis. Okay, we'll have to think about the paternal age, endocrine function, sperm DNA quality. Okay, DNA quality, lifestyle influences. Then environmental. These all will have to consider, not only semen analysis. We'll not only go for semen analysis, we'll consider these factors. Okay. Now, what are the controversies? The controversies is that we do ICSI treatment even if male factor is not identified. Okay, if we do ICSI treatment even if male factor is not identified, means we are not treating the root cause. Root cause is not being treated. We are not treating the root cause. If we'll treat the root cause, and we won't do ICSI in every patient, first we'll treat the root cause, it will improve the sperm quality and male overall health. It will improve the sperm quality and male overall health. So we'll have to treat it. Not only we'll have to do ICSI, like we are nowadays directly doing ICSI without treating the cause. We are not even looking for the cause of male infertility. We are directly doing ICSI. But we'll have to treat the patient and that will improve the semen sperm quality and male overall health. Okay. Normal spermatogenesis may require both. Normal spermatogenesis require both. What both hormones? FSH, spermatogenesis. Okay, normal spermatogenesis, FSH and LH. As we are looking, FSH acts on the Sertoli cell and it produces inhibin and it does spermatogenesis with the help of testosterone. FSH also produces ABP, androgen binding protein, which increases the testosterone level in the intratesticular level of testosterone is 100 times more than the blood. This is because of ABP secreted by the Sertoli cell. ABP is androgen binding protein. It binds the protein and it increases the intratesticular testosterone level around 100 times, 50 to 100 times we are saying. Leydig cell produces, in Leydig cell, LH acts and it produces testosterone. Okay. Then testosterone gives negative effect and inhibin gives negative effect to anterior pituitary and hypothalamus. Okay. This is the how it works. And now we'll talk about hormonal therapy. Hormonal therapy in hypogonadotropic hypogonadism by restoring spermatogenesis. We'll give hormonal therapy in first and second group, and it was seen there were mixed results. Second is idiopathic oligospermia on idiopathic group. Sorry, it's not first and second group. We'll give hypogonadotropic hypogonadic group, and we'll give it to idiopathic oligo, or non-obstructive azoospermia group. We gave hormonal therapy, and what we saw was mixed result. Mixed results were there. Okay. Then I'll talk unmet needs. Okay. There is huge unmet needs in proposed approach. Huge unmet needs in the treatment of male infertility, often empirically addressed by clinician, inspired by Positian concept for stratification. Infertile women undergoing ART and international working group proposes a new approach for men Aphrodite. As we have already discussed, in women, poor responder, we classify with Positian criteria. Same like that in male, we are classifying by Aphrodite criteria. Aphrodite aims to stratify men into subgroups and provide specific suggestion for medical handling using hormonal therapy. We are using hormonal therapy for them. Okay. Now clinical criteria for Aphrodite criteria. History and examination. First we'll see history and examination. Then in clinical history and examination, we'll ask about clinical history, any concomitant disease, malformation, cryptogenesis of onset of puberty, habitual sex life, coital history. We'll ask how many times do they met and mate, and is there any difficulty? Then lifestyle factor, smoking, alcohol, about habits we'll ask. Medication use, about what medication they are taking, we'll ask that. Now, in general examination, we'll see the body composition. Then we'll see if patient is obese. If obese patient is recognized risk factor for hypogonadism during physical examination. Then andrological examination. We'll identify hypoandrogenization. Virilization, and abnormality in scrotal contents. Okay. Virilization, why are we saying virilization? Because in male also sometimes virilization is abnormal if it's rapid in onset. There is rapid sudden deepening of voice, or quick development of severe acne, so it is called abnormal virilization in male also. Okay. Hypoandrogenization means body hair, these are less, muscle mass is less, there may be gynecomastia. That is hypoandrogenization. Abnormality in scrotal contents, there may be cryptorchidism and all. Now some term they have described. First term they described is male infertility. Abnormal semen parameter or infertility caused primarily by male factor, like abnormal semen parameter or abnormal sperm function. Okay. Then anatomical, endocrine, genetic, functional, immunological abnormality of reproductive system, chronic illness, sexual condition incompatible with the ability to deposit semen in her vagina, like hypospadias can be there. Inadequate lifestyle choices affecting fertility, and exposure to toxicants impacting reproductive health. Advanced paternal age as a critical factor along or exacerbating non-causative factors. Okay. There can be these. Now, biochemical hypogonadism. What is biochemical hypogonadism? Biochemical hypogonadism is serum total testosterone is below the reference range. Now, every guideline has their own reference range. Okay. Like European Association of Urology, EAU guidelines say 350 below is a lower reference range. In AUA, it says 300 is nanogram per deciliter is the lower limit. And in Endocrine Society, it is said 264 is the lower limit. Here in our place, with 320, we take as lower limit in our place. Okay. Then it's crucial to highlight that intratesticular testosterone concentration. Okay. It's saying that ITT is significantly more than total testosterone, up to 100 times more, up to 100 times more. Okay. Another thing, it's saying that serum 17 hydroxyprogesterone is a potent biomarker for ITT. Serum 17 hydroxyprogesterone is the potent biomarker for ITT. Okay. Now, idiopathic infertility. Idiopathic infertility means semen analysis reveal pathological finding without any. There is pathological finding in semen analysis, but there is no identifiable cause. There is no identifiable cause. There is no previous disease affecting fertility. Normal finding on physical examination. This, see, it's doing physical examination, normal finding here. Normal finding on physical examination. Endocrine is also normal. Genetic normal. Lab test is also normal. Endocrine, genetic, lab. Everything is normal. Examination, endocrine, genetic, lab, and even there is no previous history of disease affecting fertility. Only semen analysis reveal the pathological finding. Semen analysis release in pathological finding without any identifiable cause of infertility. Then unexplained infertility, normal ovarian function in female partner. How will we explain unexplained infertility? There will be normal ovarian function. See, ovarian function will be normal in female partner. Fallopian tube is normal. Uterus is normal. Cervix is normal. Actually, the definition of unexplained infertility is different. But here, the term unexplained infertility is used for this thing. Okay. Normal ovarian function, normal tube, normal uterus, normal cervix, and pelvis in female partner. The coital frequency is normal. Normal testicular function in the male. Normal genitourinary anatomy in the male. Semen analysis shows parameter within the reference range. Okay, even semen analysis is normal. Semen analysis is normal. Diagnosis potential depends on the method used and available in diagnostic tools. Now, quality of life. Multidimensional. This term is used for, it includes mental health, physical health, emotional health, emotion will make emotional health, social relationships, level of independence, access to the resources and opportunity, and overall life satisfaction. Okay, it is a multi-dimensional concept encompassing overall well-being and satisfaction, various aspects of life. Now, azoospermia. Azoospermia can be obstructive and non-obstructive. Non-obstructive causes can be genetic, congenital, post-infectious, testicular damage, radiation, genetic cause, Klinefelter, and microchromosomal of Y chromosome, microdeletion of Y chromosome. Okay, now hormones. Hormones, what is there? That FSH, I have already discussed this. FSH and LH played combined action is there for spermatogenesis. Okay. FSH secretes ABP. FSH secrete androgen binding protein. LH secrete testosterone. So intratesticular level is maintained 100 times more than the blood. Okay. Then this diagram already we have explained. Combine action. Then ITT then interacts with androgen nuclear receptor in Sertoli cell to produce sperm. Okay, that ITT now, it is, there is androgen nuclear receptor in Sertoli cell. Nuclear receptor in the Sertoli cell. Okay, Sertoli cell. So it's producing sperm from there. It is acting in the androgen nuclear receptor of Sertoli cell and it's producing sperm. Actually, total testosterone is measured. We don't measure ITT because it is invasive. So we don't measure ITT. Total testosterone is measured, and in eugonadal patient, it correlates. Total testosterone and ITT correlates. Okay. Now FSH is having inverse relationship with the spermatogonial quantity. Means if FSH is more, sperms will be less. Okay. Inversely related to spermatogonia FSH. Okay. In hypogonadotropic hypogonadism, there will be low FSH, low LH, low testosterone. Even testicular volume will be low. If FSH is more than 9 to 12 international unit per liter, there is more chances of having spermatogenic defect. If FSH is more than 9 to 12 international unit per liter, there is more chances of having spermatogenic defects. And if it is normal, that doesn't mean normal FSH does not rule out spermatogenic defects. But if there is more FSH, there is more chances of having spermatogenic defects. Okay. Now, serum total testosterone. Serum total testosterone we measure instead of intratesticular testosterone. Okay. I have already said in eugonadal patient, serum total testosterone is in unigonadal patients, serum total are closely related to ITT concentration. And HCG, if we are giving HCG treatment, HCG therapy impact is assessed through the changes in the circulatory testosterone level reflecting alteration in the ITT. ITT is invasive, so we don't measure it. We'll give HCG. After 2-3 months, we'll measure total testosterone, serum testosterone level. Okay, we don't measure ITT. Okay. Now we are coming we have come to group 1, hypogonadotropic hypogonadism, Aphrodite group 1. What is the gonad? It is defined as gonadal failure associated with reduced gametogenesis and gonadal steroid production due to reduced gonadotropin production or action. Means gonadotropin, GnRH, either its production is less or its action is less. Production or action means it's not acting, it's faulty. Okay, either production or action is less. So gonadal steroid not produced. Okay, so reduce gonadal steroid and gametogenesis. Now it can be congenital or it can be acquired. What are the congenital causes? Congenital causes is Kallmann syndrome. It is anosmic hypogonadotropic hypogonadism, means there is no sense of smell. Then normosmic isolated hypogonadotropic hypogonadism is idiopathic. It is also called idiopathic hypogonadotropic hypogonadism. Acquired causes can be drug like anabolic steroid, opioids, and testosterone replacement therapies. Or it can be infection, infiltratory pituitary lesion, pituitary tumor, hyperprolactinemia, encephalic trauma, radiation, excessive exercise, substance abuse, or systemic disease like hemochromatosis, sarcoidosis, or histiocytosis X. It can be due to these also. Okay. This is Kallmann's anabolic abuse. This is hyperprolactinemia due to excessive exercise, testosterone replacement therapy, immune therapy, injury, radiation. Okay. Now prevalence of this is prevalence of Aphrodite group 1. Okay. Agiospermic patient, prevalence is 1.9%. And male infertility, prevalence is 1.6%. Okay, Aphrodite one. Now I've already said there's here both FSH and LH will be reduced, testosterone will be reduced, and semen analysis will be reduced. Okay, all this will be reduced. Now therapy treatment. What is the treatment? GnRH pump. Either we'll use GnRH pumps or we'll use exogenous gonadotropin containing LH activity. Okay, either we'll use gonadotropin, GnRH pump, or we'll use exogenous gonadotropin containing LH activity. We uses HCG therapy alone or in combination with HCG, because HCG act like LH, है ना? A combination with HMG or HCG plus FSH. FSH can be urinary or recombinant. How will we give? We'll give HCG 1000 or 2500 HCG twice a week. This is week, we'll give twice a week. This is week, okay? So we'll give twice a week so that we'll give HCG. That means we are giving LH. So intratesticular testosterone will raise. We'll follow it by FSH if necessary. If necessary. If there is adult onset hypogonadotropic hypogonadism, HCG alone may work. Otherwise, we need to add FSH. This is exogenous gonadotropin therapy. Okay. How much here we have written? We have explained it here also that HCG we are giving 1000, 2500 for 8 to 12 week, and in combination therapy HCG we are giving 1000, 2500, FSH we are giving 150 to 300 international unit, HCG for 8 to 12 week, FSH up to 18 month. Here see again in flow chart form we have explained that either we can use gonadotropin GnRH pump or we can use exogenous gonadotropin. Exogenous gonadotropin, here we are using HCG 2000. Pubergen is HCG, no? Okay, or we can use recombinant FSH with recombinant FSH, or we can use with urinary FSH, either urinary FSH or recombinant FSH. HCG we give in the dose of 1000 to 2500 international unit twice weekly, 8 to 12 week. Okay. And then we'll check for the FSH level. If FSH level is inadequate, if it's adequate, we'll monitor and adjust the doses. If it's inadequate, we'll give FSH administration 150 to 300 international unit 2 to 3 times up to 18 months. Same we can explain with the this table also, that HCG monotherapy and HCG combined therapy. This we give for 8 to 12 week. Then we see the semen analysis and total testosterone value. This we give. Then we monitor and accordingly we adjust the dose. And here we give HCG for 8 to 12 week and FSH up to 18 month. This initial treatment to increase ITT concentration, restoration of spermatogenesis in adult onset hypogonadotropic hypogonadism. If it's adult onset hypogonadotropic hypogonadism, then HCG monotherapy will work even without FSH administration. For patient, if it's congenital or adult onset hypogonadotropic hypogonadism lacking adequate endogenous FSH concentration, will have to add FSH in HCG, enhanced therapeutic effect compared to HCG monotherapy. Now, monitoring of hormonal and semen analysis parameter during the treatment, consideration of sperm banking for responsive. If it's responsive, we'll preserve their sperm. We'll do sperm banking. Okay, we'll preserve their sperm. Now we'll talk about Aphrodite 2 criteria. What is there in Aphrodite two criteria, there will be semen analysis is lowered, the normal FSH and normal testosterone. There will be relative hypogonadism due to there is normal gonadotropin, but action of gonadotropin is reduced. Action of gonadotropin is reduced. Okay. There is genetic factor. With Aphrodite 2 and Aphrodite 3, there are genetic factor. It's a patient with idiopathic male infertility characterized by, we have already discussed, abnormal semen analysis and normal FSH and testosterone concentration. It is prevalence is 15 to 60% of patient undergoing infertility treatment. Mostly Aphrodite 2 पे होते हैं. Okay, mostly the patient is Aphrodite 2, means only semen analysis is lowered. Potential mechanism is speculated to have relative hypogonadism due to reduced gonadotropin action. Action of gonadotropin is reduced. Action of gonadotropin is reduced. Other than that, everything is fine. Like normal value of the gonadotropin is normal, but action is reduced. Means either receptor problem is there, polymorphism, or some in gonadotropin, some beta subunit can be polymorphs, or some change may be there, variation, SNV variation may be there, single nucleotide variants may be there in the gonadotropin or the receptor. Okay, that means action is reduced, not the value, action is reduced. Okay, action. Second is action is reduced. Then we'll give FSH therapy. What FSH therapy will do is, FSH therapy recombinant FSH we can give 150 to 300 international unit. What it will do is, it will increase the sperm concentration, it will decrease the sperm DNA fragmentation, and it will improve the pregnancy rate, decrease the sperm DNA fragmentation and improve the pregnancy rate. Okay. These three things will be done. And how we'll give the FSH therapy? I have already tell the doses. FSH therapy 150 to 300 alternate day. Therapy is beneficial in idiopathic oligo. Normogonadotropic non-obstructive agiospermia. Non-obstructive agiospermia with spermatogonial maturation arrest. Okay. Idiopathic oligo, normogonadotropic NOA, non-obstructive agiospermia, or NOA with spermatogenic maturation and arrest will give gonadotherapy. And in the sperm ejaculate, aim is to recover sperm in the sperm ejaculate and enhance sperm in surgical sperm retrieval. Okay. Now, variation. There may be genetic variation. Either genetic variation may be in FSHB or the receptor. FSHB is when the SNV is in single nucleotide variant is in variation, is single nucleotide variation. F is in gene encoding beta subunit, of FSH. And second is this. Okay. And second is FSR gene. FSHR gene means gene encoding for receptor of FSH. This is gonadotropin. या तो इसका बीटा सबयूनिट गड़बड़ हो गया, आइदर रिसेप्टर में गड़बड़ हो गई. क्या हो गया? SNV हो गया. SNV is single nucleotide variation. This is receptor. आइदर रिसेप्टर में सिंगल न्यूक्लियोटाइड वेरिएशन हो गया, या फिर आपका गोनाडोट्रोपिन में आपका सिंगल न्यूक्लियोटाइड वेरिएशन हो गया. or specific this affects serum FSH concentration, impacting spermatogenesis, or there may be specific alleles carrier may have inadequate FSH upregulation. Then there is FSHB 211G T. What does that mean? At position 211 in DNA sequence of FSH beta gene, guanine is replaced with thymine. Guanine is replaced with thymine. Okay. What will happen? This will decrease serum FSH concentration, reduced serum FSH concentration, decreased sperm concentration, and decreased testicular volume. Second is this FSHR. Here A to G position 2039. What does that mean is there is SNV in single nucleotide variation in FHR gene. And there is A to G, no? So nucleotide adenine is replaced with guanine. Adenine is replaced with guanine at nucleotide position 2039 in DNA sequence. Okay. Okay. Now, hormonal therapy with FSH. Either we can use exogenous FSH therapy, or we can also use, this is Aphrodite criteria 2. So we can either use exogenous FSH therapy, or we can use SERM, that is clomiphene, and aromatase inhibitor, that is latrose and anastrozole. See, what will clomiphene do? Clomiphene will improve the sperm concentration and significantly higher compared to placebo and pre-treatment. Clomiphene improves the sperm concentration. Okay. And what does letrozole? We saw in one meta-analysis that letrozole and anastrozole increases the sperm concentration and total sperm count. Sperm concentration and total sperm count. Testosterone concentration, FSH and LH also increased, and increased testosterone to estradiol ratio, but decreased estradiol. Of course, aromatase inhibitor will decrease the estradiol, and testosterone and estradiol value will be increased. This we saw in one meta-analysis. Then latrose nor anastrozole, there was no superiority over SERM and HCG. Okay. And anastrozole and letrozole and testolactone, we see in studies that this improves hormone parameter, testosterone, estradiol, and testosterone to estradiol ratio. This were improved hormone and improved seminal parameters, sperm concentration, total sperm count, and sperm motility. Latrose, anastrozole, and testolactone. These were some studies which in these studies we found these things. Okay. Now no head-to-head trial of these treatment against gonadotropin exist. Patient with primary hypo won't respond to clomiphene, and anastrozole cannot be given in hypo because there is no gonadotropin there, no gonadotropin. So how will it increase when there is no gonadotropin? FSH treatment in group 2 may be advantageous over anti-estrogenic treatment due to its multifaceted testicular response. Means FSH treatment is more advantageous over anti-estrogenic treatment. Now clinical implication. Hormonal therapy. If we give hormonal therapy before ICSI, it will improve the efficiency. First, it will improve the efficiency, and it will reduce the time to live birth in idiopathic male factor infertility. If there is no cause, it will reduce the time to live birth in idiopathic male factor infertility. Second, male NOA patient, non-obstructed azoospermia patient, hormonal therapy may improve spermatogenesis. Spermatogenesis, it will improve and to allow appearance of spermatozoa in ejaculate. So what will happen if there will be appearance of spermatozoa in ejaculate? It may be good for ICSI procedure, and we may avoid sperm retrieval, which is an invasive procedure. If there will be good amount in the ejaculate, even we can avoid sperm retrieval. Okay, and to increase sperm retrieval rates in male non-obstructive azoospermia, there is NOA. We give hormonal therapy. Spermatogenesis will occur. This will do two things. Spermatogenesis. First is sperm retrieval rate will increase. Second is there will be appearance of spermatozoa in ejaculate, which will be helpful for ICSI. We can take the spermatozoa from the ejaculate, and it will avoid the sperm retrieval, which is an invasive procedure. Means for ICSI, we can get the sperm in the ejaculate only. We don't need to do sperm retrieval. Okay. Now group 3. What is group 3 is? Group 3 is there is abnormal sperm analysis. Abnormal sperm analysis, but FSH is normal FSH. Testosterone is lower. This is group 3. Mechanism. What is the mechanism? Again, same mechanism. Gonadotropin action. ये गड़बड़ है. Gonadotropin action गड़बड़ है. तो insufficient spermatogenesis. Behind it, genetic background is at the fault. Genetic background. Okay, polymorphism. This can be called as hypogonadotropic, hypogonadotropism. Hypo, it can be called according to IC. This can be called according to ICMART. ICMART, it can be called as hypogonadotropic hypogonadism. Why? Because in its definition, ICMART, it defines it hypogonadotropic hypogonadism as gonadal failure associated with reduced gametogenesis, reduced gonadal steroid production, or reduced gonadotropin production, or action. So here comes action. Okay. Now, it's genetic factor, as we have already told that genetic factor is responsible. Genetic background, either homozygous N polymorphism may be there, or FSH beta 211G genotype, or there may be common allelic variant in FHR gene. There can be an homozygous variant, or there may be a heterozygous variant. Okay, homozygous variant or heterozygous variant. Here, see, threonine is replaced with alanine in 307 position, and this is serine is replaced with asparagine is replaced with serine in 680 position. Now, treatment option. Aphrodite 3 criteria. What are the treatment option for Aphrodite 3? Both FSH and LH. FSH plus LH activity may be beneficial. What will FSH do? FSH will increase the sperm quality. Okay, and will increase the pregnancy rate. in idiopathic infertility. Okay, FSH will increase these things, and there will be increased testosterone concentration, increase sperm retrieval in NOA patient. Means there is a correlation between increased testosterone concentration and increased sperm retrieval. If the concentration of testosterone is more, then there will be more chances of successful sperm retrieval in NOA patient. Okay. Now NOA patient are mostly hypogonadal, means steroids are less. Okay, so we'll give hormonal therapy in that. This will increase sperm retrieval, and also there will be more spermatozoa in ejaculate. How will we use? Either we'll use HCG alone or HCG plus FSH. How many times? At least 3 times per week till 3 months. 2 to 3 times per week till 3 months. What we'll use is either HCG alone or HCG plus FSH. Okay. Then patient with biochemical hypogonadism. Biochemical hypogonadism means this. What will this do? FSH and testosterone level at optimized concentration. In varying doses, titrated to keep endogenous FSH testosterone concentration and optimized level. We'll see if FSH and we'll check for FSH and testosterone level. We'll check for these level. These should be optimized. Okay. Now, what is biochemical hypogonadism? It is low testosterone, total testosterone value. Okay. This biochemical hypogonadism, or second is maturation arrest, third is hypospermatogenesis. These 3 patients benefit from hormonal therapy. What? एक तो low testosterone अगर है, ठीक है, low testosterone है अगर, biochemical hypogonadism अगर maturation arrest है तो, और अगर आपका hypospermatogenesis है तो, मतलब maturation arrest है और कम spermatogenesis हो रहा है तो, these 3 patients will benefit from the hormonal therapy. Now, clinical implication. What is the clinical implication is, even patient with a proven genetic cause, if there is a proven genetic cause of NOA, there is genetic cause for NOA, okay? Cause for NOA. Some seminiferous tubule will be working, like it's in Klippinter syndrome. Some seminiferous tubule will be working. So when we'll give gonadotropin therapy, then that will be beneficial because some may be working even if it's genetic cause. So decreased total testosterone and normal FSH. Patient with decreased total testosterone and normal FSH may benefit from gonadotropin therapy to improve GT, to improve spermatogenesis and fertility. This group 3 Aphrodite will benefit. Now further research is needed to understand heterogeneous response to hormonal therapy and identify optimal treatment regimen, especially in non-obstructive agiospermia patient. Now, Aphrodite 4. What is Aphrodite 4 is, here decreased semen analysis is there, FSH is more, decrease or normal testosterone. These are primarily NOA males. Hypergonadotropic, hypogonadism. Okay. Increase FSH and increase LH. Even they are increased, but these are endogenous gonadotropin. Okay. These are even if they are increased, they are ineffective in stimulating Leydig cell, ineffective in stimulating Leydig cell and Sertoli cell. So half of the patient has Leydig cell insufficiency. So there will be decreased testosterone. Gonadotropin therapy will give HCG and FSH. So there will be spermatogonial proliferation and DNA synthesis and total testosterone concentration will be more. Okay. Increase intratesticular total testosterone will be more, and also increase intratesticular testosterone concentration. Okay. Gonadotropin therapy, HCG and FSH will stimulate Sertoli cell and Leydig cell. Okay. This will lead to proliferation of spermatogonial cell. Cell will proliferate. Okay. Then exogenous gonadotropin. If you give, sperm retrieval rate will increase. Exogenous admission of gonadotropin might improve sperm retrieval rate, especially in normogonadotropic male, SRR will increase. But we saw in hypogonadotropin male, this hormonal therapy, in these patients also, sperm retrieval rate was increased. Okay, normogonadotropic patient, they're increasing sperm retrieval rate, but we saw that hypogonadotropic patient also, there is improvement in sperm retrieval rate. Then now we'll see Aphrodite 5 criteria, that is unexplained. Unexplained means normal FSH, normal total testosterone, and normal semen analysis is present. Yet there is infertility. These are normal, yet there is infertility, and there is no history of disease affecting fertility. Okay. No history of disease affecting. Physical examination is normal. Laboratory tests are normal. Genetic tests are normal. Still there is infertility. Here, individual treatment, we don't give individual treatment. We usually treat female partners. But these patients may benefit from FSH stimulation. Stimulatory approach may boost spermatogenesis. Okay. Now safety concentration. When we give like in ovary, we give FSH stimulation, but there is side effect like OHSS. But when we give in male this FSH, there are no to minimal side effect. Okay. And now trials showed that when we give FSH doses, very high FSH doses for long period, this is called testicular overstimulation approach. It is similar to ovarian. Okay, it is similar to ovarian stimulation approach, but in ovarian, when we stimulate ovary with FSH, there is side effect like OHSS. But when we stimulate FSH, when we stimulate testis with FSH, then no to minimal side effect is there, but quantity and quality of sperm is improved. So there will be more pregnancy rate and there will be less time to live birth. Time to live birth is decreased and there is more pregnancy rate when we stimulate testis with FSH in unexplained male. Okay. Now FSH stimulation in male with idiopathic oligo also, idiopathic oligo also, there will be minimal, there won't be much side effect. Okay. Now, supraphysiological FSH stimulation, we need to determine safety. We need to determine the safety of this. Okay. Now, clinical implication. The clinical implication is further research is needed and risk to be evaluated. FSH stimulation in men with elevated FSH and FSH secreting pituitary tumor. Okay, we saw these patients. So we saw that efficacy and safety of FSH hyperstimulation. Okay, we saw despite the hypothetical risk, evidence from the study involving FSH stimulation involving FSH in men with elevated FSH concentration and in those with FSH secretory pituitary tumor suggests potential efficacy and safety in improving spermatogenesis. Means it is safe. Even giving FSH in the patient who is already having more FSH, it is safe. Okay, theoretically it was said, theoretically it might have hypothetical risk, but it is safe when it was seen in studies. And then discussion part. Patient with this classification is not for the patient for infectious or etiology or obstructive etiology. Okay, this classification is not for those patients and it is independent. This classification is independent of etiology, and this is based on clinical description and hormonal test, routine test. Okay. Now its objective is to increase semen parameter for natural conception and ART, both, to increase semen parameter for both semen quality and semen quantity for both natural conception and ART. What is the mechanism is FSH and LH production and action. These affect germ cell stimulation. Okay, FSH and LH production and action affect germ cell stimulation. So if there is hypogonadotropism, agar hypogonadotropism will be there, then Lytic cell testosterone inefficiency will be there despite, because it's hypogonadotropin. There is something wrong with the testis. Okay, even if LH level is normal, then also there is Lytic cell testosterone insufficiency will be there, and causes may be include testicular pathology, systemic diseases, infection, genetic, aging, obesity. This may be the cause of hypogonadism. So even if there is adequate LH, there will be Lytic cell testosterone insufficiency. Okay, or then now guidelines say we'll have to evaluate both female and male, but we basically concentrate on the female part. We only see the semen parameter in male, and other than that we don't evaluate male much. So Aphrodite criteria brought a new criteria in which we consider clinical patient description, basic semen parameter, and hormonal level for more comprehensive assessment. However, right now, there is empirical approach, but there is no precise treatment, lack of precision. Okay, so for that we are now experimenting on Aphrodite criteria. This is the summary. Group 1 will give HCG plus minus FSH. In group 2, where group 1 there is hypogonadotropic hypogonadism. Group 2 is semen analysis is lowered. Other than that, everything is normal. In this patient, we can give FSH alone. Okay, mostly the patient lies in this group. This was genetic S and V was there. Then group 3, even lowered semen analysis and lowered testosterone. Okay, both. And in this FSH plus minus HCG we can use. In group 4, there is hypergonadotropic, that is elevated FSH and reduced total testosterone concentration, reduced to normal total testosterone concentration. FSH will be more here. FSH is more, and lowered semen analysis, FSH more, and testosterone will be reduced to normal. Okay. So in this, we use HCG plus minus FSH. Group 5, unexplained, we can use FSH stimulation. Thank you.